Thank you very much for inviting me to this session. I will present the case, oh, it doesn't work. Okay, the case of a 65-year-old female with a remarkable medical history who consulted to her general doctor in February of last year because of a painful mass in the leg that occurred after traumatism and that a 9-month evolution. So in April, a magnetic resonance was performed, showing a mass that suggests a chronic hematoma or myositis. So a conservative management was done at the time. In June, due to increased pain with nocturnal pain, a throughput biopsy was done in another center, and it came out to be a tumor suggestive of sarcoma. So for this reason, the patient came to our hospital. Here, we performed a new magnetic resonance showing a well-defined tumor, as we can see here, that was located intramuscular and following the Achilles tendon. It was hypointense in T1 sequence and heterogeneous with the gadolinium administration. So a biopsy was performed in our center too, showing both viable tumor and extensive areas of necrosis. The tumor, we can see that is an epithelioid neoplasm that showed ovoid nuclei with nucleolus and with some nuclear inclusion. The cytoplasm was eosinophilic with quite remarkable vacuolation of the cytoplasm, and there was a fibrostroma. In some areas, a more hyalinized stroma with these monotonous cells. And here we can see that there was a lymphoid infiltrate within. And very focally, there was this image of a really hyalinized stroma in which the cells were embedded in groups or in some isolated cells. So we can again see this vacuolation of the cytoplasm. So due to the morphology, my differential, there were myxoid stroma, focally, very focally. The mitotic activity was up to 4 mitosis to 10 high power field. And there were some images like the one that I show you here that seem to be red blood cells within the cytoplasm of the cells. So with this morphology, my differential diagnosis was first of all, a vascular tumor, in particular an epithelioid hemangioendothelioma, then a sclerosing epithelioid fibrosarcoma, an epithelioid sarcoma, or a metastatic carcinoma. Actually, I put in the differential both epithelioid hemangioma and epithelioid angiosarcoma, but as this tumor is not vasoformative, I actually don't think about this entity, so we could take it out. The immunohistochemical profile showed that the tumor was positive diffusely for ERK, CD34, CD31. SMARCB1 was preserved. There was negativity for MUC4, cytokeratins, S100, EMA, SMA, and desmin. TFE3 was positive, but with positivity that's not with an intensity that is not the one we expected for TFE3 rearranged sarcoma, because we should have this like the expression of ERK and not the one we have. And CAMTA1 is negative. So I actually eliminate all the other differential at the time, and but I was not confident in calling it epithelioid hemangioendothelioma because CAMTA1 was negative. So at that time, I made a provisional diagnosis of a sarcoma with epithelioid morphology that was grade 2 by FNC-LCC system for necrosis and mitotic activity. And that it was suggestive of AHE, but CAMTA negativity and the morphology that was not typical for a TFE3 rearranged epithelioid hemangioendothelioma. So I was not confident in calling it really a vascular tumor. So NGS Archer Fusion sarcoma panel was performed. And meanwhile, the patient was presented to our multidisciplinary sarcoma board, and it was decided to perform first surgery and then postoperative radiotherapy, depending on the final diagnosis. So the Archer came out and no fusions were found. So let's see now the gross image of this tumor when resected. We can see that is intramuscular, and it's a well-defined tumor that grow along with the tendon. There is no infiltration of the tendon and skeletal muscle that we can see in the superior part. And the tumor was firm with a central area that was harder and whitish. The morphology was quite heterogeneous within the tumor. We could see some areas that really look like what we saw at the biopsy, with these epithelioid cells, with the vacuolation of the nuclei. There were areas in which there was a more mixed edematous stroma, other areas in which there is a diffuse growth pattern with high cellularity, and focally around the morphology that was infiltrating skeletal muscles. So the tumor was not as well defined, and we see in the gross examination. So the majority of tumor was composed of this picture, like a really self morphology with a really hyalinized stroma that was embedding a group of cells, strands, or individual cells. Here we can't appreciate this great vacuolation that we saw at the biopsy. And actually, the morphology was very diffuse that way. There was mitotic activity and lymphoid infiltrate within the tumor. There was necrosis, and the central area, the whitish one, was composed of this dense fibrous stroma. So again, we performed the immunohistochemical profile, and we see that again we have this diffuse expression of vascular markers. We performed podoplanning 2 that was really positive. And again, MUC4 was negative. So actually, at that time, I was thinking about a CEF because the morphology was consistent with a CEF, but I had MUC4 negativity, and furthermore, I have this extensive vascular marker expression. So I tried to perform EWIN and FUS1 gene fish rearrangement to find rearrangement, but no rearrangement were found. And so then I came out again, sadly, with a descriptive diagnosis saying that it was a sarcoma with epithelioid morphology and vascular markers expression, but it was not consistent really with a vascular tumor at all. And it was suggestive of CEF, but there were things that for me was not sufficient to call this tumor a CEF. So again, we performed another NGS Archer fusion panel, this time the expanded version that was available at our hospital at that time. And we found a YAP1 exon 4 to KMT2A fusion and a reciprocal KMT2A YAP1 fusion. Both genes are located on chromosome 11 with the same direction of transcription and with just 16 megabases distance between them. And the evolution of the patients is quite good because she performed radiotherapy and now she's free of disease after 9 months. So let's talk about a bit about these rearranged sarcomas. There are some case reports, but the two most important works about this entity are made by Cao et al., in which Dr. Antonescu participated to the work, and Pulse et al., that are case reports, a series of cases in which they present 9 cases and 7 cases of rearranged sarcomas that involve in YAP1 or KMT2A genes. There was an equal distribution between male and female with a median age of 45 years old. The tumor could be either superficial or deep-seated and mostly affected trunk, lower extremity, or and the neck region. The evolution was not so good as we could expect it from the morphology because 2 cases had local recurrences and 2 metastases in one series, and in the other one, 2 local recurrences and 1 metastasis. And I found quite curious that metastases were not just a lung, but also lymph nodes, soft tissue, and bones. So the morphology was really similar to our morphology with a variable cellularity from hypocellular to really cellular areas, the CEF-like morphology, infiltrative borders, and the immunohistochemical profile was a bit not specific. I mean, in both series, there was a focal or weak EMA expression, and just in the first series, there was a focal CD34 and ERG expression. While in the second article, just EMA was found within this tumor. It's quite curious that in our case, there is this diffuse positivity for vascular markers, and I think this could be interesting to look at, because on one end it could be useful if all these tumors express some vascular marker to detect it, and on the other end it's important to know that this entity could express vascular markers in order not to misdiagnose as a vascular tumor. So making this presentation and studying this series, I actually came out with some themes that I think would be interesting for discussion. First of all, why there is MUC4 negativity and why there is vascular markers expression. And finally, how should we call them, a MUC4 negative CEF or KMT2A rearranged sarcoma or something else? So the first question is quite easy to solve, because we know that low-grade fibromyxoid sarcoma and sclerosing epithelioid fibrosarcoma has an upregulation of MUC4 gene. So for this reason, there is MUC4 expression. On the other end, Pulse et al. Described by gene expression profiles by the heat map, there's no expression, increased expression of MUC4. So for this reason, we can find MUC4 expression by immunohistochemistry. The other question about vascular markers expression is it's a bit difficult for me to understand why. I mean, in literature, I can't find anything about this that could explain this expression. The only thing is that YAP1, when upregulated, could promote cell proliferation and angiogenesis. So I don't know if this could be related to the vascular markers expression, but really, I don't know why. So about this, how to name that, I was thinking about it because actually, when we talk about this entity, we talk about YAP1 or KMT2A rearranged sarcomas, and there are alternative fusion patterns that may occur within these tumors. So as the KMT2A MAN2, for example, or as the VIM KMT2A rearranged sarcoma that was described by the NICO group in February this year. So even if there are a great group, the KMT2A YAP1, that has the CEF morphology, there are other rearranged sarcoma involving KMT2A, like the VIM gene rearranged, that hasn't this morphology. So I don't know if it would be okay eventually call all together MUC4 negative CEF, or maybe if there could be another name for these tumors, and I would like to know the expertise opinion about it. So as take-home messages, I think that in my case, the most important thing is to be careful when immunohistochemistry doesn't fit with the morphology, because I was almost be wrong calling it a vascular tumor. YAP1 KMT2A rearranged sarcomas should be taken into account in a tumor with CEF-like morphology and MUC4 negativity. And the evolution of these tumors is not well defined because there are low numbers of cases. So clinicians should be aware of these tumors because they should know which is the evolution we know nowadays. And so they could change their clinical follow-up. And I think we should sequence rare tumors in order to find them, and so put them together in order to see the biological potential. So with this, I finish, and thank you for your attention. And if you have any question, I will be glad to answer it.
Very nice case, Caterina, and very difficult. Maybe I can start with, some points of just discussion and controversy. I guess this is a general statement about sarcomas with gene fusions that may not have a characteristic immunoprofile. Think about the fact that there is no cell of origin, right? So for the most of these fusion-associated mesenchymal tumors. So then, depending, I guess, on the progenitors or stem cell that this fusion arises, right, may trigger different differentiation states. So that's one point. So what I'm trying to say is, when you presented the first feature, morphologic features, I think my first impression was this is a translocation associated sarcoma, right? Because of the monomorphic appearance, right? I thought that this is an epitheliohemangioendothelioma when you first show the cases and the blister cells and the typical highly nice background. So I thought it fits quite well with EHE. Then the vascular markers were, quite good, and the TFE3 positivity. I mean, there is overlap between the classic CAMTA1 EHE and TFE3 EHE. We've seen cases with, that overlap. So there's not black and white distinction. So I thought maybe it's one of these weird TFE3 EHE with an unusual pattern. But obviously it turned out not to be. I would be very careful to try to label entities so early with so few cases. We know about promiscuity of gene fusions, right? YAP1, by the way, right, is a partner of TFE3 rearranged EHE. So maybe that's not surprising at some level, right? That has the phenotype of EHE. And even maybe through a different mechanism, it activates TFE3. That's why maybe your tumor shows TFE3 expression. So at the end of the day, I'm not sure that your tumor is not a vascular tumor. I do not know. I think we have to keep an open mind when we have these rare cases with, overlapping gene fusions. I'm not a molecular skeptic, as you know, because there is another group of pathologists out there that they say fusions are not specific, it's another vimentin. It's just that we cannot comprehend at this moment how to interpret and how to put in the perspective all these molecular findings, right? So, so I'm thinking that YAP1 maybe plays a role in the morphology and your immunoprofile here. So what do we do in order to better classify or define? I think we need new tools, right? We need maybe methylation. We need gene expression to see how these cluster. Would your case cluster more with the EHE, or would your case cluster with more, SCF with, MAC4 negative? So it will be extremely interesting to learn more about these cases. And also our clinicians and clinicians everywhere give us a hard time on, what makes an entity, right? I mean, we are discovering all these new fusions which help us in diagnosis. We become a better pathologist because we have objective tools. But then, but then what's the meaning of this, right? What entity are we talking about? So it's really a challenge. The more we know, the more we find, it's challenging to figure out what entity are we talking about. So I will be a little bit cautious about, labeling entities based on one gene rearrangement, KMT2A, or I think we are not ready yet. And also as a participant of WHO, I can tell you, which is a consensus meeting, right, that there will be high skepticism in classifying sarcomas or tumors based on gene rearrangements alone, right? So we need cases like this. We need challenges, and make us question and try to maybe incorporate additional molecular tests that will expand our understanding and will get more information.
Yeah, I totally agree. Yeah.
Anything else from? I mean, it was a very, very interesting case because opens. Oh yeah, I wanted to say one more thing. When we say, or when we get a negative result from the Archer, right? Always you have to look at the genes, right? Including
exactly.
Because why was the first one negative? That means that didn't have YAP1 or KMT2A.
Yeah. Actually, it didn't have YAP1. You could catch it up with when it's fused with TFE3. So that's the reason why we couldn't detect it.
Right. Okay, so this
So
is
it's
an
another
important
thing. Yeah.
an important point
Section
out
burn.
there, and I'm glad you were able to test it again on a bigger panel. But if you are thinking of certain entities and you are kind of want to exclude certain gene rearrangements, look at the panel, right? Because nowadays, you know, they differ. Here at Memorial, we have now 123 genes, right? Other places have 20 or 50 or 60. So you really have to look very carefully and see if the, you know, the genes you're interested in are on that panel. And if, you know, in your case, even if the second Archer came back negative, I would still have maybe send it out for a larger panel, a 500 gene panel on Illumina, you know, for discovery, because it really looked like a fusion positive sarcoma.
Yeah.
So very, very good case, Caterina.
Hi, thank you very much. Thanks.
Are we doing okay with time? I mean, we can talk for an entire hour, you know, about this case. It's really, you know, it's just, you know, fusion of entities, right? Not only fusion of genes, but it's very, very challenging and to me very interesting. And it's unfortunate that we cannot also look at RNA expression from these Archer panels to see where your case clusters. For example, the French sarcoma group in Curie or Lyon, they do whole transcriptome instead of this targeted panel of, you know, 100 genes. They do whole transcriptome either in frozen or paraffin. So they can cluster, right? They can cluster the case, like your case, not just get the fusion, but see where it clusters, because you get these weird results and then what? Right? And then you don't know. So I think in your case would have been extraordinarily important to see where your case is clustering, right? Because it expresses the vascular marker, the TFE3. It looks like an EHE to me. Of course, there is overlap with KMT2A, no question about it, right? But it's just a fascinating case.
Yeah. It would be really interesting to see it actually. Yeah, in the article of Pulse et al, they did it, and actually their cases cluster with myxofibrosarcoma, very curiously, because it's not a fused sarcoma, but they didn't cluster with SEF actually.
Yeah, it all depends again, right? It all depends how many cases you have, how many entities you have, right? So
yeah.
I do not know the details right now on their control, I mean their reference. So but yeah, I think it's work in progress.
Yes, it is. Yeah. Thank you so much.
Of course.
So hello everyone. I'm Jan Wan from Shanghai, China. It's evening in Shanghai and morning in New York and afternoon in Central Europe. So it's a very interesting cases. I mean, if we without NGS, based on the morphology and the immunophenotype, we may call it epithelial hemangioendothelioma. So I will just raise a question. Could it be a variant of epithelial and hemangioendothelioma with CAMTAN2 rearrangement? That's my question. Okay.
Yeah, definitely. Yeah, that was my point as well. Because of the YAP1 and the immunoprofile and the histology, this may be, I'm not 100%, but maybe a variant of EHE.
Yeah, yes. Okay, anyway, very interesting cases. Thank you very much.
Thank you.
We may continue with Luis.
Okay. Let's go. Well, here. Okay. Can you hear me?
Yes.
And the presentation, can you see it?
Yes.
Okay, good afternoon, good morning, and good evening to everyone in the audience. It's a pleasure for me to present this case, and I want to thank Dr. Machado for inviting me, and Cleo Romagosa for coordinate this project, and obviously Dr. Antonescu for being here with us and as a coordinator or as a moderating this session. My case is not so complex as the case of Caterina, but let's go. Let's go there. This is my disclosure. I declare no conflict of interest, and let's go. My case is about a 60-year-old man who was accidentally shot in his left knee while hunting 36 years ago in 1986. A surgical arthrodesis of the left knee was performed. This is just a representative or illustrative X-ray of the knee of the patient, but this is not the original X-ray, right? This is just for see the X needle that traumatologists put in that time. And a few months later, one of these needles was removed, right? Well, the patient came to our hospital in January of 2020 complaining of a pain and swelling of the left knee after a sudden trauma. Initially, good response of non-steroid anti-inflammatory was observed. And 3 months later, in March of 2020, you can see this is the original X-ray of the patient with one needle. And the radiologist saw probable chronic osteomyelitis versus post-traumatic infection process versus giant cell tumor in the differential diagnosis of radiologists, probably because of these changes here. But this is a knee very complex, right? Because the patient suffered an accident 36 years ago, and you can see the ankylosis and the arthrodesis of this knee. Well, this is the scan of the knee, and you can see the pathological deposit of the trusser here. And here is the uptake of the fracture focus and osteosynthesis material is the needle you can observe here, right? And this one is from July of 2020. The second needle was removed here. And the radiologist described an osteolytic lesion involving the distal epiphysis of the femur and proximal epiphysis of tibia. The fibula was respected at this moment. And this is the scintigraphy, and you can see here, and markedly increase of uptake of the trusser, and it was compatible with the infection, but it's necessary to rule out a tumor for the nuclear doctors. And then, let me see, a subcutaneous open biopsy of soft tissue component was performed. It was about 1 or 2 centimeters in great diameter. And areas with this fashion here, fascicular pattern, spindle cell morphology, as you can see here, was the morphology of this tumor in some areas, but in other areas, the tumor show round to ovoid cell morphology with prominent nucleoli and a kind of epithelioid or something like that. A lot of mitotic figure was observed. And this is other area with round to ovoid morphology, the same morphology as the last picture, mitotic figures, some pleomorphism pattern with a typical mitosis. And necrosis was observed also in some areas as a geographic necrosis with island of viable tumor cells in the middle. This is another area of the tumor. This was a very heterogeneous because the biopsy is not more than 2 centimeters, but a lot of patterns in the same biopsy. This is a perivascular distribution of the cells. And you can see here the same pattern. It's a little bit weird for this tumor, and the vessels doesn't show a plexiform pattern or specific rearrangement or distribution, right? This is a CD31 immuno, and in some areas, intercellular spaces, clear spaces, was observed, and I interpret this like edematous or myxoid stroma, maybe. But here you can see a blue, kind of blue gray material, intercellular material that was positive with Alcian blue staining. And I thought that there was a myxoid stroma in some areas. And in summary, we have a bone and soft tissue mass on the left knee in a 60-year-old male, fast growth, inflammatory, infectious versus tumor on radiology and clinical examination. And the morphology was a tumor with sheaths and fascicular growth pattern, at least focally, round, ovoid, and spindle cell morphology, highly vascularized stroma areas, atypia, mitosis, necrosis, no osteoid or new bone formation in any area of the tumor, of the biopsy, and myxoid stroma in some areas. So, sorry. Let's continue. Here comes my first question for Dr. Antonescu. Based on the characteristic previously described, how do you recommend to continue the study in this case? The classic way, you perform immunohistochemistry, FISH, or NGS, or you directly perform NGS or something?
I would go the old way. I will go with immunos first. Because of the nuclear pleomorphism, the variegated histology you described, this is not, in my mind, necessarily a fusion-associated sarcoma high on my list, right? Okay. So age-wise and the prior trauma, to me, it's more like a high-grade undifferentiated sarcoma type of entity, rather than a translocation-associated tumor. So first, of course, I will do IHC to make sure this is sarcoma versus carcinoma versus other things.
Okay, thank you very much. You have answered my second question about the differential diagnosis. Thank you. This was my differential diagnosis, and you may think that I'm crazy because of this differential here. This tumor, undifferentiated small round cell sarcoma, is not frequent in all people, and you need probably molecular techniques to confirm this kind of tumor here. But some cases have been described in all people, and I'm a young pathologist, and I don't have a lot of experience in this tumor, so I thought I have to rule out these two. But osteosarcoma is a good option. But my problem in this case was that I didn't find osteoid or osteoid probably, and that myxoid areas was very extended in the biopsy. So I was confused with this option. And finally, I thought also in a poorly differentiated synovial sarcoma that is infrequent or rare in bone as a primary tumor, but secondarily involvement of tumor was observed in at least 20% of cases. And bone primary synovial sarcoma have been described also. Let's go to the immunos. This was CD99. It showed positivity of membranous and cytoplasmic in some areas, but not diffusely, right? And you can see here some cells that were negative. So this is not the typical pattern of CD99, for example, for an Ewing sarcoma, if you agree. NKX 2.2 was also, it was negative in all the areas of the tumor. Cyclin D1 and WT1 were both negative. EMA, TLE1, BCL2, and SSX18 and SSX were also negative. I and I1 was preserved or retained in this tumor, and MYZ was positive in approximately 50% of tumor cells. And finally, SATB2 show diffuse and strong positivity in tumor cells. And this is the summary of the immunos, right? Positivity just for CD99 focally, SATB2, INI1, and CMYC. I don't have BCOR or SIG to perform in my hospital, and this was the negative markers: cytokeratins, smooth muscle markers, skeletal muscle markers, S100, HMB45, and sanitophysin were negative. We also performed FISH in this case, and this is, I don't have pictures of the FISH, but this is an illustrative image from this paper here. And we don't found rearrangement of EWSR1 and SS18 or SEAT. So this probably rule out the possibility of EWIN or EWSR1 non-ETS tumors and synovial sarcoma. But interestingly, MYC was not rearranged, but it showed a 3-copy trisomy, or this is not a karyotype, but this is suggestive of a trisomy, right? It was observed in 31% of the tumor cells, and these have been described as a frequent event or phenomenon in this kind of in this tumor, SIG-DUX4 rearranged sarcoma. But not only in this sarcoma, but it has been described as a frequent event, not only trisomies, but amplification of CMYZ in osteosarcoma. And it was a problem for me in that moment. So this is my summary table with a lot of criteria I include in my differential diagnosis. And if you pay attention, the option with a lot of green checks here is osteosarcoma, and clinically and radiologically probably is the best option, right? But I couldn't confirm this option here because I don't have FISH or molecular techniques or NGS to rule out these options. And synovial sarcoma at this moment is I thought this is not the diagnosis, the correct diagnosis, so I could rule out this. And you may say this guy is crazy, but my diagnosis, my initial provisional diagnosis was a genetic kind of diagnosis, and I talked about undifferentiated small round cell sarcoma with a comment. The cytogenetic study FISH suggests a complex karyotype. However, samples of this tumor will be sent to a reference center as a consult case and for NGS analysis to rule out these possibilities. And I have to thank Cleo Ferro-Magosa. She was very kind, and she accepted my case as a consult case, and she performed NGS with this Archer Fusion Plex sarcoma kit, and she didn't find SIG rearrangement. The immunohistochemistry for BCOR was also negative, and FISH for SIG was also negative. So we were talking about this case, and we agreed that this is probably a high-grade tumor, and in this site and in this clinical context, this is probably an osteosarcoma high-grade, right? And let's continue. In September of 2020, this was the MRI. You can see here the osteolytic tumor with large soft tumor component here, which makes it characteristic difficult for the radiologist. And they conclude, and this is the first time they they talk about osteosarcoma as a option for this image here. And this black hole here in the center is because of the bone cement the traumatologists put inside. This was the treatment for this patient: a surgical radical supracondylar amputation of the left leg. And you can see here this is here the surgical scar, the primitive surgical scar, and down you can see here the open surgical wound with necrotic and hemorrhagic areas. The soft tissue and subcutaneous tissue was affected by the tumor with a lot of necrosis. And this is before fixation in a longitudinal section of the piece. The tumor was very heterogeneous with destruction of bone, medular and cortical bone, with extension to the soft tissue, with extended areas of necrosis, hemorrhage, etc. This was 17 centimeters in diameter, larger diameter. And this is after fixation, the same characteristic. The fibular bone was respected. And this is a kind of Kalman triangle, maybe, but radiologists never talk about this possibility. So I was lost with other options, right? But this is probably the classic aspect microscopic or gross appearance of a high-grade osteosarcoma. And obviously in the microscopic examination, I could observe this bone formation, new bone formation, and osteoid was easy to see right now. So a lot of osteoid or this kind of material with a lace-like pattern was observed in a lot of areas. So this is the typical case that in a biopsy you can have or with you dealing with you have very problems to diagnose because osteoid is an essential criteria for this diagnosis, but I didn't find it in my previous biopsy. And a lot of pleomorphic cells with atypia and atypical mitotic were observed in a lot of areas with vascular invasion. And my definitive diagnosis was finally a high-grade osteosarcoma with lymphovascular invasion. It was a PT3 stage. And lung metastases, the patient present lung metastases a few months after diagnosis. So the oncologist started chemotherapy. This was the first line of chemotherapy. And 2 years later, in 2022, the patient presented bilateral lung metastases and pelvic metastases. So this is the chemotherapy the patient received, 5 lines of chemotherapy with toxicity, progression to different lines of chemotherapy. And finally, the patient died of a pulmonary infection. So this is some of the references I have used for this presentation. And my last question for Dr. Antonescu is about the MYC. How is your experience about the prognosis implication of MYC gene alteration in sarcoma other than angiosarcoma or osteosarcoma? And if you think that should we inform these MYC alterations in our pathology reports? And thank you very much for your attention.
Yeah, very interesting case, and we, a lot of things we can discuss here. And I'll mention the MIC issue later. But I think maybe a clue in the diagnosis here is the patient history, right? He had this gunshot trauma many years ago, which that translates into a bone infarct, or fibrosis, necrosis of the bone, and that is a well-known factor for developing osteosarcoma years and years later. So that's one clue. Second, the morphology that you showed was so variegated, right? From spindle fascicular to epithelioid to round, undifferentiated / anaplastic. So this morphology is unlikely, as I mentioned before, to be a fusion associated sarcoma. Based on the morphology, you know, the spindling, I would not even do CD99, and because CD99 can stain so many things. So I only do CD99 in round cell sarcomas, not these type of tumors that have so many different morphologies. B-core, of course, can have a spindle cell morphology, but typically doesn't show epithelioid, right? Chick ducts may show undifferentiated, some spindly, but not that much this epithelioid morphology you showed. And as you said, that would be kind of a zebra, right? Statistically speaking, those two entities are so rare, right? In this patient presentation and anatomic site. Think about chick ducts 4 overwhelmingly in soft tissue, right? So rarely occurs as a primary bone tumor. Then I guess what else? Let's talk about SADB2, right? Because whenever you have a primary bone tumor that shows this variegated appearance, of course, number one choice would be high-grade osteogenic sarcoma. It's not uncommon for radiologists not to be helpful. So on this side of the Atlantic also, you know, they're not necessarily helpful in adult bone tumors, so they may not see any sclerotic component of the tumor matrix formation. But as I said, primary bone sarcoma, number one on the list will be an osteogenic sarcoma, right? And then, so SADB2, diffuse positivity, as you showed, will be an indication that you are dealing with a high-grade OS, even if, right, in your small sample, you don't see osteoid. The alternative, in my opinion, would have been a UPS of bone, right? Primary UPS of bone that has areas of pleomorphic spindle, epithelioid, myxoid, right? So that would have been an alternative here. If this patient would be a child, right, we would have pushed it into osteosarcoma even based on the biopsy, even in the, you know, the lack of osteoid deposition, just based on SADB2 and the, you know, heterogeneity of morphology. So the patient can be treated with, you know, high dose methotrexate and osteosarcoma regimen. In an adult 68, it's debatable how, you know, how much chemo can. So here the differential, in my opinion, would have been UPS versus high grade OS. And of course, after the unblock resection or amputation, the presence of osteoid became obvious. You asked me about MYC. I mean, MYC alterations are quite common in sarcomas, and as you showed, in osteosarcoma. So I'm not sure that will help as a diagnostic marker, to be honest with you. You also said MYC has been shown to be, you know, gained or amplified in chick ducts, but this is a very non-specific finding in general. I cannot comment much about MYC amplification as a prognostic marker, other than you said angiosarcoma and osteosarcoma. I have not looked at that in, you know, with other histologic types, but for a diagnostic marker, I'm not sure that will help us getting anywhere. So this is interesting. Again, SADB2 by itself is not specific, right? You know that B-core sarcomas express SADB2, and maybe that was one of the reasons you wanted to exclude a B-core sarcoma. But in this context, Yes, in this context of a primary bone lesion, a patient that had an infarct many years ago, I think is a factor that is telling you that most likely this is a true marker of osteogenic or osteoblastic differentiation, and your diagnosis should go towards osteosarcoma.
Okay, thank you very much. Yes, MIG was just an incident, or we performed this fish and we didn't have idea of what it means, but reading the literature, yes, it's frequent even in osteosarcoma too, but not as a useful tool for diagnosis, as you say. Yeah.
And if you were thinking, along the lines of a genomically complex sarcoma, right, which osteosarcoma and UPS are, if you would have done, for example, NGS, right, not Archer, you would have
Ideas,
done
okay.
DNA targeted sequencing, or even SNP array, right? You cannot tell the difference much, because both UPS and high-grade OS are show mainly copy number alterations, and they have p53. So to be honest with you, this differential molecular cannot really help much. Radiology, as I said, SADB2, good sampling, right, to identify osteoid, but other than that, at molecular level, since we are discussing that, just a very complex alterations, mainly copy number, amplification losses. So that could also may have helped you in order to maybe exclude all the fusion positive sarcomas that wouldn't have all these alterations. So that could maybe have supported the fact that you are dealing with an osteosarcoma rather than translocation positive tumor.
Okay, thank you very much.
Excuse me, but there is a question in the chat box. Can you see? Maybe for both of you.
I didn't hear you.
Yeah,
Sorry.
Sorry, that there is a question from Silvia Baguet in the chat box.
Okay.
Maybe for you both.
Yes, because of the location epiphysis, could malignant giant cell tumor of bone be considered in the differential? Yeah, if it was epiphyseal, I'm not sure. It was such a big tumor. I guess it was epiphyseal as well. Yeah, have you done the histone 3 immuno to explore maybe a malignant / sarcomatous transformation in a giant cell tumor bone, Luis?
I'm not sure. Giant cell tumor bone, but giant cell were not frequent in the piece, the whole piece, right?
But sometimes, the giant cell tumor is completely obliterated by the sarcoma. I guess in a biopsy, right, you can't really tell, but maybe when you had the resection, you sample it well, I guess you didn't see any giant cell tumor component. But in a biopsy, I think would have been a good idea to do this marker. Would have just pointed out to the pre-existent benign lesion, right? Because all the rest, I still think it fits with an osteosarcoma or UPS, right? That in this case may have started in a giant cell tumor bone. I'm not aware that the trauma and infarction would predispose for a giant cell tumor bone. I know for sure that it predisposes for osteosarcoma, but I don't know about giant cell tumor.
I don't know either. For osteosarcoma, of course, it is a conditioning, previous trauma.
Right.
Dr. John Bart, you want?
Yes, just a very short comment. I agree with Cristina. That is, I think that if Dallin other Bertoni, we have seen this case with the clinical history, which is very demonstrative of what we are dealing. They will have directly forward diagnosis as an osteosarcoma. And we have to be very aware of what we do, because we spend a lot of money in diagnosis, which are not always mandatory to do. And that is my point now. We have to be also very careful, and we have to try to be more reliable on the HNA, that in this case, even if you don't see the presence of osteoid, you have to think in one osteosarcoma.
This is the new generation.
Yes, that is the difference
No
with me.
pathologists, so it's a different stuff.
I belong to the old generation. That is why I trust much the HNE.
No, of course. I think the new generation is incorporating, right, everything and going back to HNE, which is great. But of course, your point is well taken. I think based on the history, the location, right? I always tell this to my fellows and residents, you know, don't go with the zebra. Just think about what's the most common tumor here, right? Statistically speaking. And then try to go with that, because otherwise, you know, of course, there are rare chick ducts that have epithelioid, there are rare chick ducts that grow in the bone, but those are, you know, less than 0.1%. So I agree with, you know, the comment from Dr. Lombard Bosch that it's good to still incorporate the clinical information and the old HNE. You know, that's still our friend. We don't give it up yet. And we have plenty of uses for molecular in other things. As you know, I'm you know, the biggest fan of molecular, but I think morphology still goes very strong, and I would never give it up. And you know, your question initially, if I go straight to RNA, never, right? Now, still, you know, even if I know on HNE that this is likely a translocation associated, still I'm trying to kind of go through the, you know, motion and what will be the differential and do some immunos and then kind of expect certain fusions and make sure that our panel has it. So it's never, okay, Archer. So I don't want to kind of disconnect from, you know, the old way. I never met Darlene. I briefly met Bertoni. So there are really big names in bone pathology. So I think they would have gotten this. Yes, I agree. Thank you. We can go to the next case.
Yep.
Okay. I'm going to share my presentation. You can see the full presentation.
Yes.
Okay. Hello to everyone in every part of the world. I'm Dr. Tulio Silva from Valdebrón University Hospital. I work there as a bone and soft tissue pathologist with Dr. Romagosa. And with no further introduction, I'm gonna start with a case. Okay, this case involves a 43 years old male that consults for systemic symptoms of fever and anemia. A thoracic CT scan was performed and an anterior mediastinum mass of about 7 centimeters was observed. Well, these are the images of the thoracic CT scan showing the mass and its relationship to with the right atrium, the aorta, the pulmonary right artery, and the lung parenchyma. Okay. We received the biopsy specimen. This was a consultation case. And this is the panoramic view of this biopsy of the mass that shows an irregular, unencapsulated nodule with different cell density. At low magnification, we observe monotonous small cell proliferation in a fibrous mixed stroma with cystic changes associated with scattered lymphoid infiltrates. Okay. At higher magnification, at this area, the cells are arranged in cords with the presence of loose cells. The tumoral cells show eccentric hyperchromatic nuclei with scant eosinophilic cytoplasms. If we move around the tumor, the cell population changes and the tumoral cells at this area look bigger with epithelial appearance, arranged in nests and strands. At higher magnification, the tumor cells showed well-defined oval nuclei with a small nucleoli and clear vacuolated cytoplasms with low mitotic activity and no necrosis. Okay, summarizing, it was a 43-year-old male with a mediastinum mass showing an unencapsulated tumor with a proliferation of monotonous of a small to epithelial cell proliferation, arranging nests, strands, cords, and discohesive cells in a fibromixed matrix with cystic changes and lymphoid infiltrates with low mitotic activity. So at this point, we were wondering the cell lineage of the tumor with the morphology at this location. So we decided to perform a wide differential diagnosis considering tumors of an epithelial, mesothelial, mesenchymal, or even hematolymphoid origin. And based on that, we performed our first immunohistochemistry panel. So the tumoral cells express cytokeratin CAM5.2, showing intense and diffuse expression, and also pan-cytokeratins with a weak positivity, both with a dot-like pattern. WT1, the N-terminus antibody, showed nuclei positivity, carotene and D240 were negative, and BAP1 with not loss of expression. So with the immunohistochemistry panel performed, we ruled out the possibility of a lymphoma, also with the morphology, based on the expression of keratins and CD45 negativity. Also applied, we also applied a wide panel of immunostains to exclude the possibility of lung carcinoma, neuroendocrine carcinoma, carcinoma metastases, or even rare tumors such as node carcinoma or germ cell tumors, showing no expression for these markers. So the idea of an epithelial tumor was losing power in our differential, even though it's not totally discarded. So what about the possibility of a traditional mesothelioma? We thought it was less likely because of the immunophenotype of the tumor and also the morphology. But in the other hand, the option of a epithelioid malignant mesothelioma was a good alternative, although rare, and the negativity for cytokeratin 5 and 6, carotene and D240 also negative, and the presence of discohesive cells could be against that possibility, even though we think it was a good option. So regarding the possibility of a mesenchymal tumor or others such as neurogenic tumors or melanoma or rare tumors such as SMARCA4 deficient tumors, well, the tumor showed isolated and weak expression of for desmin, shown in the picture, and negativity for neuroectodermal markers and no loss of SMARCA4, making that options less likely. Summarizing the most remarkable immunohistochemistry results, we have expression for pan-cytokeratins, expression for CAM5.2 in a dot-like pattern, WT1 positivity, the N-terminus antibody, also positivity in a weak and isolated cells for desmin, and no loss for BAP1 and carotene and D240 negativity. With that features, we consider the possibility of a desmoplastic round cell tumor as a location and the morphology. We thought it could fit with our tumor. As you know, and this tumor can be present in young patients, as in our case. It can also be located in the thoracic or in the thorax. Can show this nest to small round epithelial cells or oval with oval hyperchromatic nuclei, even though we didn't see like high mitotic activity or even necrosis, but for us was a good option. Also for the immunophenotype, the positivity for keratins, and also we have some of expression for desmin. So we try to give it a try to this option and try to look the EWS translocation with a fish. So we performed a fish break apart probe that was rearranged so it could fit with our hypothesis. So adding to our summary, the EWS rearrangement, the features observed so far, well, even though not perfectly, fit our diagnosis of a desmoplastic round cell tumor. So a preliminary diagnosis of DRCT was performed, and we were waiting for an NGS confirmation. So we performed an NGS Archer sarcoma, and to our surprise, this is the gene fusion that we got, an EWS ATF1 fusion gene. Okay, we were expecting the EWS WT1 of the desmoplastic round cell tumor. So with the NGS result, our hypothesis was not fitting as expected, right? Even though unspecific, as the EWS ATF1 fusion gene can be found in several entities from different cell lineages from mesenchymal, neuroectodermal, and epithelial origin, as angiomatoid fibrous osteocytoma, clear cell sarcoma, or even hyalinizing clear cell carcinoma. This fusion gene is present in epithelial mesotheliomas, and if you can recall, that option was in our differential, so it was good to know that. Recently, a subset of malignant epithelial mesotheliomas have been described as tumors present in young patients, also in pediatric populations with no asbestos exposure, located intra-abdominally or in pleural cavities, composed of epithelial cells with focal papillary architecture, with cytokeratin and WT1 positivity, and no loss of BAP1. Okay, features that can fit with our tumors, right? So we still have some features that are not fitting entirely perfect, but I think, or we think it's still a good option for this tumor. As these pathological features of the tumor were overlapping between entities of different cell lineages, we decided to stop, rethink, gather again all the information as the clinical feature, the morphology, the immunohistochemistry panel, the molecular findings. We talk with other colleagues at different areas to try to rebuild with all the information this puzzle. At this point, we have to be honest. We also contact with Dr. Antonescu by email, and she kindly suggests us to read about an entity described by her group that possibly can fit to our tumor's features. This is the publication where they describe a distinctive malignant epithelial neoplasm with EWS, past-crept fusions with predilection for mesothelial cavities. Okay, this tumor was described in 13 young patients with no asbestos exposure, located mainly intra-abdominally and in pleural cavities, shows epithelium to small and spindle cells proliferation with cystic and microcystic changes, presence of lymphoid aggregates like in AFH, or showing some resembling to this tumor. Cytokeratins and WT1 positivity, no loss of BAP1 and carotene negativity, that also can fit very well with our tumor's features. on this paper, they performed, or they show us this true-site RNA fusion panel gene expression showing EWS CREM fusion positive lesions grouped together with separate from other EWS CREM positive tumor entities, suggesting the possibility of a potential novel entity, as you can see in this diagram. So these two options can fit with our diagnosis, but is it possible to classify our tumor as they share all these mentioned features? This is like the main question, I think, here. Currently, our patient is on a chemotherapy regimen. The tumor has not grown in 7 months and only has, the patient have side effects to treatment. So I think this is the time where I give all the floor to Dr. Antonescu, and I have prepared some questions regarding this, if she can help us or mentor us with her experience. So my first question here is, what is the best approach for these tumors as pathologists? If we don't have all these technologies of, if we are not able to identify or tear them apart with NGS, that in this case it was not possible.
I can start by saying that Dr. Dalin wouldn't have gotten this case right. Well, I'm not sure we got it right? But I mean, yeah. Who's the judge out there, right?
Yeah, exactly.
So let's start with you know, your question about this being an epithelioid mesothelioma in a young adult, relatively young adult, with EWS ATF1 fusion. In our series, most, if not all, cases that we included there were classic mesotheliomas with papillary features. This one, right, does not look like exactly your classic mesothelioma. So that's one reason I wouldn't go there, knowing that we have now a different entity, right, that is coined by this fusion, that, you know, it has an epithelioid morphology, expresses cytokeratin, and has this dual features, right, of angiomatoid fibrocystocytoma in some of our cases with lymphoid aggregates, and then cystic changes, and then the relationship with the mesothelial lining, right, that would suggest, as you said, an epithelioid mesothelioma. So this is the first entity that we saw within the EWS CREB fusion that shared, right, features from two different entities. Again, the jury is out there. If this represents a separate entity, you showed there our RNA-seq clustering. We have very few cases, right? Yeah, 2 cases. What can I say? Most cases, they look distinctive, as I said, occur in the mesothelial lining, cytokeratin. So it looks like it may be a separate entity. And I'm not convinced this is mesothelioma based on morphology.
Yeah. Yeah.
I thought this would be a desmoplastic round cell tumor, the way you are going, right, with cytokeratin and some desmin and WT1, right? The only thing that was a bit suspicious is not a desmoplastic round cell tumor, was the epithelioid component with those clearing and more abundant cytoplasms that usually you don't see in the DSRCT. When I saw that, I also thought about myoepithelial tumor, right? Myoepithelial tumors can show that. And then when you got the EWS, I was still considering a myoepithelial tumors. The myoepithelial tumor family now is growing, and it may lack, you know, S100 staining, but, you know, with this fusion, I don't think myoepithelial tumor is in the running. So I think that's the best fit in 2023. Maybe we can revisit this entity in 10 years and hopefully it will get incorporated somewhere in the WHO. These things evolve so fast, right, that only time will tell.
Okay. And regarding the second question, what do you recommend to say to our colleagues, I mean, oncologists and surgeons regarding prognosis or treatment? Because I think that's challenging for us when we perform, or we didn't label this tumor. We state that probably is in the spectrum of this novel potential new entity. But of course, the first question was, okay, so what are we going to do with this?
First of all is grading, right? Because you
Yeah.
show few mitosis, so it's not necessarily the highest grade sarcoma or tumor you've ever seen. So from that perspective, I will not necessarily say, okay, give chemotherapy to this patient. So, I mean, if it's resectable, just watch. I didn't catch that. Maybe it wasn't resectable, right? Because
No, it was not. It was not.
Right. So then there are not that many choices. Can you radiate? I guess close to the heart. They don't have many drugs anyway. So I don't know, to give the conventional soft tissue sarcoma chemotherapy. I guess they can try that. You know, treat like any other soft tissue sarcoma. Would they think about giving a mesothelioma chemotherapy? So here, you know, when they realize this is a borderline entity, we are not 100% sure what it is, you know, I would say, why don't you treat as a sarcoma? They treat as a sarcoma, maybe it's not responding, and then
Exactly.
they maybe switch to a mesothelioma. I mean, it's not set in stone, right? We have
Exactly.
to keep the dialogue with our oncologists. That's why, you know, the relationship with them has to, you know, it's very important for them to trust us when we say we are not sure, and then they can try different things.
Exactly.
If it was resectable, I wouldn't have suggested any additional adjuvant therapy, but obviously this is not resectable.
Yeah. So far, the patient is with a sarcoma, Ewing sarcoma regimen, and the tumor is not growing, it's stable, but
Okay.
so far, yeah.
It's very toxic, right? The Ewing sarcoma protocol.
Yeah, exactly.
So
Yeah. And finally, what are your thoughts regarding classifying tumors from the molecular point of view? I think you've been saying during these presentations, you were talking about this topic.
I'm planning to retire soon, so you guys, the new generation, have to take over this. And you know, we did a lot of work here, described a lot of fusions, but this is just the surface, right?
Yeah.
Now we have to understand what each fusion means, and you know, as you say, prognosis, treatment, what are the therapeutic targets. So we are so far away from, you know, understanding this. I think molecular pathologists just made us better pathologists, right? More objective criteria. I mean, before molecular, how would you have called this? Probably desmoplastic round cell tumor, right? It's still a sarcoma, but you know, it's good to know, right? Knowledge is very important. It's the first step of treating better, managing better. But as I said in the beginning, we have to keep our minds open. We don't really know if they are true entities, right? And EWS Krebs family, right, of tumors, it's such a good example of, you know, fusion promiscuity and then overlapping morphologies. And so, you know, good and bad altogether. Good that we have something objective, bad because we don't really necessarily understand.
Thank you very much.
But it seems like you guys have all the tools to figure every single case out. You're not missing out there, and you have great cases and great learning material.
I have a question. That's very interesting case, Tulio. My question is that, actually, in the real life, when we see a pleural tumor with cytokeratin and WT1 positive, the first that we came up is mesothelioma. So I don't know how many mesothelioma previously diagnosis could be fit in this new entity, but the reality is that usually when we see cavity tumor with this epithelial morphology and cytokeratin and WT1 despite lack of carotene, we may call this in the past mesothelioma, but now we should consider this entity.
I'm not a world expert in mesothelioma, but you know, I don't see a lot of these, and to me, just looking at it, it looked like it could be a sarcoma. You know, it could be a fusion positive tumor. It was very monomorphic. I don't know if epithelial mesotheliomas have this monomorphic histology. You've done the BAP1, there's no asbestos. I mean, there are things against, right? It's not
exactly.
So then if you see doesn't add up, I think it's important to go further, right? To go and see if, you know, a fusion panel. So in a case like this, I would definitely go with NGS after we, you know, we do the immunos and we have our differential and we kind of think maybe doesn't fit into a mesothelioma, let's go deeper. So I hear you what you're saying. Yes, clinically it would make sense, but then you didn't have some things that you should have with mesothelioma. So in a case like this, I think was a great idea for the Valdebron team to go further.
Yeah, we try to, as I said, talk with colleagues from other areas, with the pathologists in charge of the lung and mesothelial cavities in the thorax, and they were exactly they guide us in that way that they told us probably it's not going to be a mesothelioma, go further because.
Yes, I think very important to share cases with your thoracic or other specialty because they will hold your hand. They will say, "Oh, this is unusual for mesot." So then you can go further, because if they would say, "Oh, it fits into me," then you know, maybe you wouldn't have proceeded with RNA-seq.
Exactly.
So, but it's a very good case to discuss these issues in, you know, in like intersecting disciplines, and you know, sometimes we agree with other disciplines, sometimes we don't agree, right? But in this case, it seems like was a consensus that likely was not a mesothelioma. Yeah, very, very interesting case. Thank you for putting them together and, you know, finding these. This is really a treasure for us to discuss in a group. And I also enjoyed the format because you guys didn't make me work, you know, present slides. You know, you can hear my opinion without a formal presentation. So I think the format works very well.
Okay. Thank you very much for this interesting session. So we usually do this session monthly. The next month is supposed to be organized by Claude because I have personal issues to resolve. But in July we have a similar session like this with Jason Hornick from Boston. We will present also free case, Claire, Enrique, and myself. So if you want to participate, Cristina, you are very
More than
welcome. So,
I can be on the mailing list, so you know, if
yes.
I'm available, I'm happy to to question Dr. Hornick.
Okay, so thank you
Thank you,
again
everyone, and have
for
a
your
great
time.
evening. Thank you. Bye.
Bye. See you.
Bye.
Bye bye.
Thank you.
Bye bye.
Thanks. Bye, Dr.
Thank you.
Antonescu.
Bye.